of IAP Raigad. IAP Raigad is known for conducting various academic activities like this. We have successfully conducted various CVs since last few months, and they have been very much successful. Today, we are having this unique CME on UTI, and we are so fortunate to have none other than Dr. Pankaj Deshpande sir, who is a well-known national figure in the area of pediatric nephrology. And we all know him. He is so close to us, especially for IAP Raigad. He has taken care of our kids since years, since I think 2 decades almost. And he will be guiding us regarding this particular topic. Dr. Babri sir, who is a senior pediatrician from Roha, will be moderating the session. And we are also very happy to have Dr. Ramakant Patil, EB member of Maharashtra IAP, our senior pediatrician Dr. Abbas, who also joined. Dr. Anjali Gokar madam, she also joined. And also particularly Dr. Amol, who is also a young pediatric nephrologist, new addition to New Bombay. And he is also very much available to all of us for our nephrology cases. And all these senior pediatricians also, they can add their wisdom in between whenever they want to. Now, at the end, our dear President, Dr. Vanpiri sir, who has actually thought of having this CME, and he thinks out of the box to have such kind of CMEs. So now I request our dear President to give his 2-line presidential address.
Thank you, Vikas. Thank you very much. Today's our guest speaker, Dr. Pankaj Deshpande sir, our EB member and President IAP 23, Dr. Ramakant Patil sir, our senior members, Dr. Abbas sahab, young nephrologist, Dr. Amol sir, IAP Palghar President, Gokarna madam, I welcome you all. Dear friends, about UTI, we know each and everything about it, still we miss it. And the consequences of missing UTI at the early age has to face the consequences in adulthood by the patient. Just to avoid this, we have to pick up it early.
Hello.
We have to treat it early completely. We have to investigate. Just to solve our queries, questions. We have got Dr. Pankaj Deshpande sir, who is very friendly with us, but he guides us about pediatric nephrology, about our nephrology patient. So let us get an opportunity to learn from him, from his wisdom talk. I request him to start. Before that, I request Dr. Anand to take over the charge, being a moderator, to moderate the session. Thank you very much.
Good evening, friends. We are meeting today to discuss a very common issue that we all very frequently encounter, UTI in office practice. Urinary infections affect all age groups, right from a newborn baby to older children, and of course, adults. Females are significantly more affected than are males after infancy. UTI is generally caused by colonic gram-negative bacteria, which find their way to the urinary tract, the urethra, bladder, ureter, right up to the kidneys. Infections can affect the urethra and or the bladder, causing cystitis. They may ascend up the ureter and affect the kidneys, causing pyelonephritis. Hence, we see a variety of symptoms associated with UTI. Dysuria, polyuria, urgency, abdominal pain, fever, malaise, nausea, vomiting, etc. Newborns may exhibit fever, irritability, poor feeding, unexplained crying, and sometimes loss of weight. A fair number of patients may show asymptomatic basiluria. Recurrent UTI episodes can injure the kidney and may lead to renal scarring and insufficiency. How scientifically do we clinicians approach these clinically common situations? How much of evidence-based medicine do we practice? Do we investigate UTI adequately? Do we treat UTI appropriately? How do we tackle the complications? To address these questions and more, we have today in our midst our very own Dr. Pankaj Deshpande. Having trained in pediatric nephrology at various centers in the UK, he worked there for well over a decade. Now practicing in New Bombay, he is attached to the prestigious Hinduja Hospital, Mumbai, the Apollo Hospital, Navi Mumbai, and the Bethany Hospital, Thane. He has to his credit numerous presentations at ESPN and Indian conferences. Dr. Deshpande will now make his presentation. These will be case-based scenarios with a lot of interactions from all participants. Colleagues are free to ask questions. Over to Dr. Pankaj Deshpande.
Thank you. Thank you, Anand, for that glowing introduction. Can I share this screen now?
Yes, sir. Yes.
Yeah. You can all see the slideshow?
Yeah.
Okay. I think Anand made my job very easy because he described a lot of UTI completely. And what I'm actually going to look at is something different. So as he rightly said, it's one of the common problems that we see in our OPD practice. And yet there are many confusions with regards to urine infection diagnosis and treatment. So what we are going to try and unravel is these confusions that we see in the OPD practice. So this is not an inpatient admitted sick PICU patient. We are talking of OPD patients who present to you where we suspect a urine infection. And more, as I have written there, maybe we would need to learn what is not a UTI, because they say you learn 5 new things every day. And most of the times what you learn is that what you learned yesterday was wrong. And so that's what we probably need to learn. So let's start off. And as I always say, our patients teach us a lot more than what our textbooks and guidelines can. So let's look at these cases that presented to the OPD. So this is a 3-year-old boy who presents with a history of fever for 1 day. There is no focus that you can find on examination in the OPD, and the fever is mild. The mother and brother have a cold, but you don't find anything in the child. Now, because we do a urine test in fever without focus, this is the urine test that is being done. So as you can see, the color is yellow, specific gravity 1025, protein 1+, trace blood, pus cells 12 to 15, and RBCs 1 to 3. Now, this child comes back in the evening with this report, and by then he has developed a cough and a runny nose. So the first question that comes to our mind is, are we going to treat this as a urine infection? Anybody can just answer and then we'll go forward quickly.
No, sir.
No, I think that's fairly evident, and that's what we need to understand, that pyuria is not pathognomonic of urine infections. So when we say significant pyuria, it is presence of more than 5 pus cells in the high power field in a centrifuged urine sample, or more than 10 per cubic millimeter in an uncentrifuged urine sample. But significant pyuria can occur in many conditions. It is not only in urine infections. So any fever anywhere because of any reason can give rise to pus cells in the urine. Dehydration can also cause pus cells in the urine. If you have nephritis, whether it is glomerulonephritis or interstitial nephritis, you get inflammatory cells in the urine, which are basically pus cells. And if you get renal calcura or hypercalciuria, that also can lead to pus cells in the urine. So equating pus cells with urine infection is fallacious. We'll go to some other points also in that. But the first point we need to remember is that just because you see pus cells in the urine in a child who's got fever does not mean that the child has a urine infection, especially if you find another focus. Because when we talk of urine collection, as we shall do later, there are very specific criteria in when you do a urine sample. And if we don't follow those criteria, we're going to go around in circles trying to treat something which is not a urine infection. This is the second child, who's a 4-year-old girl who presents with abdominal pain, which is present on and off. The child has no fever or urinary symptoms. You examine the child and the child is perfectly normal. And now you send a urine test. Don't ask me why it was sent, but it was sent. This is the report that you got. Protein 1 plus, trace of blood, 2 to 4 pus cells, RBCs 1 to 3. And an ultrasound was done because the child had abdominal pain. Now the ultrasound reported normal shape and size of the kidneys. As you all know, we look at the impression rather than reading through the report. And the final report or the impression which is given is a thickened bladder wall, which is suggestive of cystitis. So the question now comes, shall we treat this UTI or not treat this UTI?
Not to treat.
Not to treat. I think the lesson that we need to remember is it's not the impression on an ultrasound scan report that is important. Yeah, to just give you an example, I have put a picture here. Now this is a bladder which will be called thick walled. Now this is the wall of the bladder. This is more than 2 millimeters. The thickness is defined as anything more than 2 millimeters is called as a thick walled bladder. But the same bladder in the second picture is now thin walled bladder. So you can create thickened bladder similar to cystitis. You can create a bladder which is thin walled, and that depends on the volume of urine that is present in the bladder. So if the bladder is collapsed, it will be thick walled. It's like the balloon which is inflated or deflated. A deflated balloon will be thick walled. A deflated bladder or a collapsed bladder will be thick walled. So if you do not look at the pre-void and post-void urine, post-void becomes important, we'll talk about it later, but pre-void volume of urine is also important. So there are various formulas. One of them is given there, age plus 2 multiplied by 30. But even if you remember age multiplied by 30, that is good enough. So this child is 4 years old. So the volume of urine in the bladder should be at least 100 to 120 ml for you to comment on thickness of the bladder, suggesting cystitis. If that is not present, commenting on thickness and equating it to cystitis is erroneous and fallacious. So don't go by what the sonography report or the radiologist is telling you. The diagnosis of urine infection is based on clinical symptoms and a urine test, not on an ultrasound scan. The other reports that you often get, the similar, exactly the same history. Now you have sent the child for an ultrasound and the report comes back as saying normal kidneys, the bladder looks normal in terms of thickness, but there is floating debris in the bladder suggestive of cystitis. So is this a urine infection now?
No.
No. Right, because we need to understand that floating debris, yes, urine infection can cause floating debris, but it's not the be all and end all of causing floating debris in the bladder. What they are basically seeing is some floating particles in the bladder that can occur in children who have gross hematuria, but more commonly it occurs because the child is drinking inadequate fluid. So you can have mucus in the bladder which looks like particles and they get reported as floating debris, or amorphous phosphates can also be floating around in the bladder and give rise to this. So as I said, the symptoms of the child and a urine test will determine whether the child has a urine infection and not the presence or absence of something on an ultrasound scan. The third thing that often they will report, the same kind of girl, now you send the child to an ultrasound scan and the report comes back as saying that the kidneys are normal in size or shape, but there is increased echogenicity of the kidneys. So either one side, two sides, and there is grade 1 or grade 2 medical renal disease. Now this is often interpreted as being equal to pyelonephritis. Now that's not really true. Increased echogenicity, normally when we say, I think there is a picture I put there, yes. So normally this is the kidney here and this is the liver. This is the right, the pointer is at the liver and this is the right kidney. So normally the kidney should look less echogenic, which means it should look blacker than the liver. Here, as you can see, the kidney is looking brighter than the liver. That is what they mean by increased echogenicity. Now, there are different grades of echogenicity that have been given. So grade 1 is where the echogenicity is more. Grade 2, it's equal to the liver, and grade 3, it's more than the liver, and so on and so forth. But that's what they mean by increased echogenicity of the kidney. Now, in this case, it's not just the echogenicity, but there is a loss of CM differentiation also. That's a different matter altogether. But increase, just because you see increased echogenicity does not mean that there is a urine infection. So what we need to learn is diagnosis of urine infection should be only on the basis of a urine test after the symptoms that suggest a urine infection. Only the other issue that often crops up is a presence of a bit of protein and blood in the urine test. That is not evidence of a urine infection, and that should not be chased with antibiotics. You cannot have pyelonephritis, so changes in the kidney being present as increased echogenicity, which is equal to pyelonephritis. You cannot have pyelonephritis in a child with no symptoms and a normal urine report. To finish off, what are the causes of increased echogenicity? Pyelonephritis is just one of them. So you can have interstitial nephritis giving the same picture, and interstitial nephritis is often either caused by a different infection. So it may be a respiratory infection, or it may be antibiotics that have been given to the child. There you will see increased echogenicity. You can have acute glomerulonephritis, which can also cause this increased echogenicity. Nephrocalcinosis, early nephrocalcinosis may be seen as increased echogenicity. And most importantly, the child that I showed you the picture of, renal dysplasia can present this way, which has been present from birth. You have done an ultrasound just now and you have picked it up. That does not mean this child has a urine infection. Right. The next girl is a 7-year-old girl who had abdominal pain. There were no other symptoms and she had urine tests done. Now, the urine routine showed 1 to 2 pus cells and the culture showed more than 1 lakh organisms per ml, which were E. coli. So the question is, how do you treat this urine infection? Do you treat it, not treat it?
It may be contaminated, sir.
Correct. So I think we look at reports so frequently, but we do not spend time in explaining how to collect urine. And I've got a slide about how to collect urine, but more importantly, if you ask the parents as to how the urine was collected and transported to the lab, you will find that this particular girl, the urine was taken at 7 o'clock in the morning. The father put it in the pocket and the lab opens at 9 o'clock. He stayed far away. He sat in a bus and traveled 2 hours and then gave the sample there. Now that itself is completely wrong. A urine sample that is left in room temperature for more than 1 hour will show growth of contaminants, which is equal to a significant growth of a colony count. And that is not a urine infection. So we need to spend time to explain how you collect urine. Now, collection of urine is the most important aspect of diagnosing urine infection, because otherwise we are going to call everything as a urine infection. So the first point is in a child who's suspected of having a urine infection. Now, when do we suspect a urine infection? We suspect a urine infection if a child has fever without focus, and there's a little qualification for that, but right now I'm not going to go into that. I'll come back some other time and talk about it. As I kept talking, telling Dr. Wankhede, there's something that's coming up. Or you have a child who's got urinary symptoms. So fever without focus and or urinary symptoms is an indication to do a urine test. Only abdominal pain in an older child is not an indication for doing a urine test. You can have as many as 150 pus cells in the urine in a child who's got acute appendicitis. That is not evidence of a urine infection. So in a child where you suspect a urine infection, you clean the genital area with only water or normal soap and water, not an antiseptic soap. You collect a midstream urine sample, which means that you discard the first part of urine, collect the middle part, or in a little baby, it can be a clean catch urine. It needs to reach the lab within 1 hour. And if you cannot make the sample reach the lab within 1 hour, it needs to be kept in the fridge, not in the freezer compartment, but in the chiller, 4 degrees centigrade, up to 24 hours. And in girls, you need to make sure that there is no vulval redness. If you have vulval redness, you will get all these reports being abnormal. In this, if you have collected a midstream urine sample, a growth of 100,000 organisms or 1 lakh organisms per ml of a single species. If you get 2 species, it's a problem. That means it's contaminated. If you get this growth of a single species, then we say that there is a urine infection that has been diagnosed. So this next girl is a 2-year-old girl who had history of fever for 2 days. There was no significant past history in this girl. She was well grown. There was no systemic abnormality on examination. Now you send the urine test off, and this is the report that you get. The specific gravity is 1015, color is yellow, protein is absent, pus cells 3 to 4, and nitrites positive. Now we have all been taught about leukocyte esterase and nitrites because they are very specific. Now this child comes back in the evening with this report. By that time, the child has developed a cough and cold again. Now, would this be a urine infection? And if not, then how would you explain the nitrates? So let's move on. If you really are interested in a urine infection, even when you get a nitrate positive, a culture has to be sent. In this girl, you don't need to send it because you need to find out how the sample was taken. As I said, we often don't do that. So if you ask the parents, you would have found out that the sample is taken in the morning, it has been looked at in the evening, and when you get a stored urine sample at room temperature, this kind of report is very evident. So you need to know the false positive nitrite test, because though it is specific, if you don't know the false positive nitrite test, that will be diagnosed as a urine infection again. So the common reason for a false positive is if the urine examined is not fresh. Secondly, if you keep on opening the box of dipstick for nitrites frequently, then if they get exposed to air, then within 2 weeks, 50% of the sticks start reading a false positive nitrite test. So you need to be very careful to close the cap as soon as you have used a stick, because otherwise you will get false positives. And some medicines can give rise to a false positive nitrite test, medications like phenazopyridine. So this next girl is a 5-year-old girl who had fever for 2 days with no focus. Nothing is found on examination, and a urine test is done. Now this shows turbid urine, significant pyuria 50 to 60 per high power field, 5 to 10 RBCs. So a culture is sent and the child is started on cefixime. Now 5 milligram per kilogram per dose twice a day. So on follow-up, after 48 hours, the child is afebrile, has no symptoms, and the urine culture has shown E. coli, but it is resistant to cephalosporins and sensitive only to injectable antibiotics like amikacin and the penems, the carbapenem and all that. So the question is, now would you admit this child for IV antibiotics? Anyone wants to answer?
Yes, sir.
You would admit?
Admit means we will give IV antibiotics.
Right. So I think the point is, what we are looking at is resolution of symptoms. So if the symptoms resolve, there is no need to change antibiotics, because the MICs that are done for the sensitivity test are MICs in blood, and urine concentrations can be much higher of the antibiotics that you are giving. So very often you will find that the symptoms have resolved, in which case you do not need to change antibiotics. Clearly no need of admission in such a scenario. So the symptoms of the child are far more important than what the sensitivity is showing. If the fever continues and the symptom hasn't resolved, then clearly you need to change to IV antibiotics. Otherwise, there is no need of changing. Now, you do an ultrasound scan at this stage, because I don't think I have put that slide here because that wasn't the remit of this. So in a urine infection, the 3 tests that we do is an ultrasound, a DMSA, and a cystogram in an infant. So an ultrasound is to be done as soon as possible. In a child who's admitted, you do it during the admission. In a child seen on an OPD basis, it has to be done within the first 2 weeks. So you do an ultrasound scan of this child in this week, which is reported as showing normal kidneys. There are 2 hypoechoic lesions, which are 1.5 centimeters in the left kidney. the bladder is normal, and the impression, which is what we look at the end of the day, says possibility of an abscess cannot be ruled out, and the radiologist has suggested a CT scan. So the question is, what are you going to do now? Are we going to do a CT scan or admit and give IV antibiotics? Anyone?
Sir,
Right.
would like to
So carry on. Yeah.
give antibiotics.
No, antibiotics you are giving. So would you admit then and give IV antibiotics?
Yeah.
Okay. Right. So the symptoms and the clinical scenario of the child dictate what you are going to do. We have already said this child is completely resolved in terms of fever and whatever symptoms the child carried. So just because an ultrasound shows something does not mean it's an abscess. So if it is an abscess, fever will never go away. If it is a significant abscess, the fever will not go away. So if the fever has settled, it is an unlikely abscess. So these are parenchymal changes which are present during an acute urinary tract infection, which can resolve as quickly as in 2 weeks, or sometimes they can take up to 6 weeks to become completely normal. So if the child's symptoms have resolved, you do not need to change antibiotics and do not need to change your plan of giving antibiotics. But in this child, not that you would anyway not do it, but you should never forget a DMSA, because you've got acute changes which are parenchymal. And if these become long lasting or permanent, then the long-term prognosis of the child changes. So a DMSA scan has to be done. We'll talk about that later. Now this child, so you have left the child on cefixime. 10 days later, you repeat a urine routine and a urine culture. The urine routine shows 20 pus cells and the urine culture shows E. coli, now 10,000 organisms per ml. So question is, have you incompletely cleared the urine infections? Would you now admit and give IV antibiotics? Yes or no?
Yes, sir.
Right. So I think the answer is no. I'm sorry. But a repeat urine culture is not required in a urinary tract infection where the symptoms have completely resolved. Right at the beginning, when we talked of urine collection, we said a urine test is done only when you have these two particular symptoms, which are fever without focus or urinary symptoms. Now, this child has neither. So why would we do a urine test in the child? To find out whether the infection has cleared up, you never do a urine test. So a urine culture is 100% not done. And a repeat urine routine in an asymptomatic child also has absolutely no significance, because the pyuria, as we discussed in the first case, can be because of multiple reasons. So you do not repeat urine tests at the end of the course of antibiotics to find out if the urine infection in terms of investigations has disappeared, because it's more important to find out whether the clinical resolution has occurred, as it has in this child. So you would finish the course of antibiotics and leave the child alone. But now what would you do further? Because this child has been advised to do urine routine every month to look for urine infections. So should that be done in this child is the question. Yes or no?
Yes, sir.
Right.
But
Again,
sir, how would you come to know that we have treated it completely or not?
the clinical resolution is more important than investigative resolution. So if the child's
urine is showing still pus cells, you said.
No, but clinical resolution, the fever disappeared, and after 10 days of antibiotics, the child is perfectly well. So why would you repeat it?
Okay.
Okay. Now, doing a urine routine every month to look for urine infections is completely pointless. The reason being that urine has to be tested when the symptoms are present, as we just discussed it for collection of urine. And when we are saying surveillance samples, why should it be 30 days? Why not 15 days? Why not 7 days? It has no meaning. So you do urine test, you may need to do 4 urine tests within 5 days, depending on what the symptoms the child is displaying. But doing a surveillance sample every 15 days, every 13 days has absolutely no role in management of a urine infection subsequent to treatment. Okay. The next child, this is an 18-month-old girl who has high-grade fever for 24 hours with occasional vomiting. There is no focus on examination. A urine routine done shows 80 to 100 pus cells. The white cell count is elevated in a CBC. A urine culture is sent and the child is admitted and started on IV ceftriaxone and amikacin. Do you agree to this management?
Yes, sir.
Right. So why 2 antibiotics? Which guidelines suggest 2 antibiotics?
The ceftriaxone would be alone would be sufficient.
Yes. So all the guidelines are very clearly telling us that you need only 1 antibiotic. Now, if the child doesn't respond, if there are other complications, that's a different matter. But a child who has presented to you with an antibiotic, with a urine infection and looks sick, needs to be admitted, you start off with 1 antibiotic. Now, if you have done a culture sensitivity, let's say for this child earlier, and it shows that it is sensitive to nitrofurantoin, would you use nitrofurantoin for treatment in this child?
No.
Why?
Because of some toxicity?
No.
Doctors.
No. So the point is there is no recommendation for 2 antibiotics, as we just said, oral or IV. So single antibiotic to begin with, and nitrofurantoin is not to be used for acute treatment because the concentration that it achieves in the parenchyma is extremely low. So it does not treat the parenchymal infection. It is very good for treating cystitis and the lower urinary tract. That's why it's used for prophylaxis, but it's not used for acute treatment in little children. Older 15-year-old girls coming with cystitis, if you want to use that, that's a different matter. So nitrofurantoin is not to be used for acute treatment of a urine infection in younger children. It can be used for prophylaxis. Right. The next one is a 4-year-old boy who has history of fever and dysuria. The urine routine shows 30 to 40 pus cells. Urine culture has grown a significant colony count, so 1 lakh organisms per ml. This child is treated with oral antibiotics for 10 days. The symptoms have settled down. You get an ultrasound done which shows normal kidneys and bladder. And you do a DMSA scan 8 weeks later. Now this is the picture. It may not be very clear there, but at the upper and the lower poles, you are seeing a reduced uptake. So when you read the report, what is written is there is scarring in the left kidney at the upper and lower pole. It is also there in the right kidney, but mainly in the left kidney. So the question is, what are you going to do with this child? The DMSA shows scarring in a child who had a urine infection.
Renal function.
Yes. Anything more that you would want to comment on this? We'll talk about renal function and all that later. The point I'm trying to make here is that it is important to know when to do the tests in a child who's got a urine infection. We already talked of an ultrasound. A child who presents to the OPD as an office UTI should have an ultrasound as soon as possible in the first couple of weeks. Child who's admitted should have an ultrasound during the admission. But a DMSA scan, this child had a repeat DMSA done after 6 months, and you can see pristine kidneys which are completely normal. Now remember, when you say scarring is fibrous tissue, which means that normal kidney tissue has been replaced by fibrous tissue. It cannot revert back to normal. So the function is normal and there is no evidence of scarring. So what did this child have? This child had acute changes, which is what we talked about on the ultrasound scan, which showed the changes on the ultrasound, hypoechoic areas. Acute changes can take up to 6 months to resolve on a DMSA scan. So doing a DMSA scan too early is fraught with problems. I know the guidelines say 2 months, 3 months, but it's not 2 to 3 months. It should be done at least 6 months after the urine infection. The second important thing to remember is all that is reported on a DMSA scan, though they call it scarring, is not always scarring. So DMSA done after 6 months once the UTI is treated. And remember, the scarring cannot differentiate between, the DMSA scan cannot differentiate between scarring and dysplastic area. So what happens in a DMSA is you have injected the color in a vein, it is taken up by the proximal tubular cells, and functioning kidney tissue is lit up, and therefore you can see it on the gamma camera. Now, what happens when that area is not functioning is it's reported as a scar. It is not necessarily a scar. You have never done a DMSA before. You could have a kidney which has dysplastic areas, and you will never be able to differentiate it from scarring. There are differences in the appearance, so wedge-shaped defect and all that. But generally, nuclear medicine people do not understand dysplastic areas from scarring, and it is difficult to differentiate. So they report everything as scarring. Right. The next child is a 4-year-old boy who presents with puffiness of the eyes and face for 8 days. There is no past history that this child has, no fever or dysuria. You do a urine test, and because there is puffiness, you are obviously looking for nephrotic syndrome, and you find 4+ protein, and it also shows 15 to 18 pus cells. The albumin is 1.8, cholesterol is 315, which confirms your diagnosis of nephrotic. But the question is, does this child have nephrotic syndrome with urine infection? Would you give antibiotics?
Yes, sir.
Okay.
First trial of antibiotics.
Again, the answer is no. The so-called pus cells are inflammatory cells. If I change the scenario and now say that this child has come with red colored urine and high blood pressure, and a urine report is showing this along with 4+ protein and plenty of RBCs, you would not treat the pus cells because you know it is glomerulonephritis. And in glomerulonephritis, you expect certain number of pus cells to be present in the urine because these are inflammatory cells. Now, a nephrotic syndrome is not different from a glomerulonephritis. There is an inflammatory process that is going on in the kidneys. So it is not surprising that you will find a few pus cells in the urine. So just because you see pus cells in the urine does not mean that it is a urine infection. Unless there are symptoms of a urine infection, this is not a urine infection. This is just inflammation, just like in nephritis. So don't treat these pus cells as urine infections.
Sir, in this case, should we go for culture then?
No. If the child has symptoms, do everything. If the child has no symptoms, these are just inflammatory cells present because of inflammation seen because of the nephrotic syndrome. So you don't need to do anything for them. Okay?
Yes.
Right. So this next girl is 3.5-year-old girl who has history of fever, which is high grade. There is no focus found. A urine routine was sent, which shows 40 to 50 pus cells. Urine culture shows E. coli, which is 1 lakh organisms per ml. So confirmed urine infection. This child is treated with antibiotics for 14 days. Symptoms resolved in 2 days' time. And the child goes home. Now the child comes 1 month later with similar symptoms. The urine shows pyuria of 60 to 70 pus cells. The urine culture again now is showing Klebsiella, which is significant growth. Now this child is admitted and given antibiotics for 5 days and oral antibiotics for 10 days. So you have ceftriaxone and then cefixime. You get an ultrasound done, which shows normal kidneys with no dilatation. And the child goes home about 6 to 8 weeks later, about 2 months later, this child comes back with a similar episode. Again, there are 50 to 60 pus cells. Culture shows E. coli, which is significant growth. And now the child is treated with even a higher antibiotics, Piptas. So the question is, what are you going to do? This child has 3 confirmed episodes of urine infection with a normal ultrasound scan. What would you do in this child? Anybody?
Don't know, sir.
Which test would you recommend? Because that's what I'm trying to imply here. So the common conception is that we need to go in rush and do a micturating cystourethrogram because that is what is advised, recurrent urine infections. Now, she had an MCU which showed a normal bladder with no vesico-ureteric reflux. So now where are we? Because we are so focused on the investigative part of urine infections that we do not recognize that there are simple measures that need to be looked at first before we jump into investigations, and which could have been done even in the first episode of a urine infection. So the simple preventive measures are what? So we need to spend time talking to the parents rather than advising tests. The commonest reason for repeated urine infections in children is constipation. So if you do not clear constipation, this child will keep on coming with urine infections irrespective of whether there is reflux or no reflux. So it's constipation itself is the second is leads to infrequent voiding in older children. So both of these together can give rise to urine infection. And one of the things, as we talked about earlier, you will look at pre-void volume on an ultrasound scan. So you need to start asking this on an ultrasound scan, not just pre-void, but post-void residue. So if you have a post-void residue of greater than 20 ml in a child who's more than 3 years of age, then it is a very high risk factor for getting repeated urine infections. So this is what this child had. This child was severely constipated with a post-void residue of 40 ml. And unless you address this issue, she is going to keep on coming with repeated urine infections. Now, treatment of constipation is very prolonged. As you know, it can take months for you to clear off. And therefore, the child will keep on coming with urine infections. Now, what will you do in the intervening period? Now you have started treatment for constipation. You are now going to look at that post-void residue. But in the intervening period, what are you going to do? What advice would you give the child? So we all think about, we will come to that in the next slide. But if the same thing happens in a boy, then you would give the same advice, but you will also make sure that the prepuce is retracted or can be retracted and cleaned during a bath every day. Because if the prepuce cannot be retracted, then the risk of getting a urine infection in phimosis is extremely high. So those who come with repeated urine infections and have phimosis with all other tests being normal, you may want to treat the phimosis. So you can use creams to soften the prepuce. So steroid creams can be used. And if it doesn't help, then you can consider circumcision. Circumcision is not the first step to be used for a child who presents with one urine infection. So if they get repeated urine infections, you may consider circumcision if simple measures fail. But in both of these, whether it's a boy or a girl, in the intervening period, till you are trying to sort out the issues that may be causing the urine infections, you will consider prophylaxis. So prophylaxis is not only for children who have vesico-ureteric reflux. It can also be used in cases with frequent urinary tract infections till you sort out the causative factors. And when I say causative factors here, please understand that if you've got a child who's got, let's say at 3 years of age, comes to you with a severe urine infection, and for whatever reason you do an micturating cystourethrogram and you find grade 4 reflux at that time, that still does not explain why the child developed urine infections. Because for 3 years, why did the child not have urine infection? So clearly something changed that made the child develop a urine infection. So if you get rid of the factors that caused this urine infection, reflux by itself may never be a problem. So those factors need to be treated, and that is what is called as bowel bladder issues, constipation. Sorry, you said something? Oh, so constipation is the commonest factor. So prophylaxis is to be given to these patients. Prophylactic agent, as you know, an ideal agent should be a cheap agent which can get rid of bacteria other than the periurethral flora. So the ideal prophylactic agent should not get rid of the periurethral flora. Unfortunately, there are only two agents which can do that. One is trimethoprim and the other is nitrofurantoin. All other prophylactic agents, and both of these are not easily available for us because nitrofurantoin is a very vomitogenic agent and trimethoprim alone is not available. It's available as Septran and sometimes it's there in the market, sometimes it's not. only tablets are available. So what we use as cephalosporin, cephalexin 10 milligram per kilogram per day, is not an ideal agent because it changes the periurethral flora. But when you do start this prophylaxis, usually you give it for a period of 6 months to 1 year. In this case, you may give it only for 3 to 6 months till you are sure that all the factors have been taken care of and the child is not going to develop repeated urine infections. The last point to be made about preventive agents or prophylactic agents is that you do not need to rotate prophylactic agents. The single agent that you have given for prophylaxis should be continued for the period of 6 months or 1 year. You don't need to change it every month. The dose that you use, so nitrofurantoin is given in a dose of 1 to 2 milligram per kilogram per day. Cephalexin, we already said, is used in a dose of 10 to 15 milligram per kilogram per day. And trimethoprim component of Septran should be 1 to 2 milligram per kilogram per day, given as a single dose, preferably at night in an older patient. In a younger patient, it doesn't matter. The idea is that you want to prevent infection when there is stasis of urine, and when the child goes to sleep, maximum stasis occurs in the bladder. Therefore, you try to give it just before the child goes to bed. So prophylaxis is something that you need to remember even in patients who may not have reflux, to prevent recurrent urine infections. Right. This is the 3-year-old girl who presents with fever on day 1, has a urine routine sent which shows 10 to 15 pus cells. A urine culture is sent and the child is started on antibiotics. The child develops a URTI as it often happens on day 2, and a urine culture after 48 hours shows no growth of organisms. Now, when you get no growth, you always have to confirm that the culture was sent before antibiotics were started. Because very often, even a single dose of antibiotics may change the growth. Now, this girl clearly does not have a urine infection because the culture is negative, the child has a focus, and just because of pus cells, you don't call it a urine infection, but this child was labeled as a urine infection. The parents were actually doctors in this case. Now, she had an ultrasound scan which showed normal kidneys with no dilatation and the bladder was normal. And she had a micturating cystourethrogram which showed bilateral grade 3 vesico-ureteric reflux. So now the question comes, what are you going to do about the reflux? You're going to advise surgery, put the child on prophylaxis. What are you going to do? I think
observe the child, no prophylactic.
Correct. So the diagnosis of UTI is a conglomerate of many factors taken together and not just pus cells in the urine, as we just said. So just because you saw pus cells, you called it a urine infection, now did tests. Now reflux has been present from birth up to 3 years of age, which I said earlier. Now, why has this child not developed a urine infection? The child hasn't developed a urine infection. So why do you want to change anything? Have there been any studies done to show that reflux occurs in normal people also? Yes. Philip Ransley did it in 1977, long time back. Now, that today is impossible because ethics committees will not allow you to do those kind of studies. He did MCUs in all the neonates who were admitted in an NICU or the HDU also, so normal babies. And he found that nearly 1% of the children had reflux. Now, none of these were going to develop urine infections. Only a few of them were going to develop urine infections. So this is what I said, that something changes which causes a urine infection. Then that usually is either the child gets constipated, there's a problem in voiding, and therefore you get urine infections. So just because reflux is there does not mean that you need to go running around with a gun to shoot out every reflux that is present. So the first UTI with a normal ultrasound scan at 3 years of age anyway does not warrant an MCU. But if you have done an MCU and you have found reflux, it is an incidental finding. And remember that it's present from birth. And VUR can be present in normal children also. So only vigilance for urine infection is what you would advise this child, because this child has never developed a urine infection. and tell the child to present to you soon if any of the symptoms occur. Now, this child is now an adult. She's never developed a urine infection and she never had any prophylaxis. So just to bring out the point that just because you see reflux doesn't mean that we go running around with a gun to fix every reflux present. Right. This is an 11-year-old girl who presents with frequency, urgency, and dysuria at times. There is occasional daytime wetting, which is pre-void. There is no fever. A routine urine done shows 10 to 15 pus cells. The urine culture is sent, and this is the culture report. There's no organism. And this child has been having these similar symptoms in the last 6 months. So again, the urine routine showed 6 to 8 pus cells and the culture showed 10,000 organisms per ml in a midstream urine sample, which was clearly not significant. This child had an ultrasound done, and I'll show you the report of the ultrasound. Forget all that is written there. But again, the impression is there are small bilateral renal scars. And again, the ubiquitous, what they have said is cystitis. So this girl is 6 years old. So the volume should be 180 ml at least. And that's why they are calling it cystitis. So with the scars in the kidneys, does this mean that the child has been getting repeated urine infections, now needs a cystogram, and now you need to do something else? What do the scars mean?
Are there withholding manures in this child?
Yeah, we'll talk about diagnosis. I'm asking about the ultrasound report. We'll come to that, holding maneuvers in a minute. What would you do about the reported scars?
How can they report the scar on the sonography?
Correct. So I think the point I'm trying to make is ultrasound is not the investigation of choice for detecting scars. Okay, ultrasound does not detect scar. You can actually do comment on the scars by measuring the distance from the mid of the kidney to the capsule. That's a very dodgy thing to do. In fact, fetal lobulation very often gets misread as scars on an ultrasound scan. So if you really want to look for scars, you have to do a DMSA scan. The DMSA is a dynamic scan which tells you about the static scan which tells you about reduced uptake and the presence of scars. So in these children, if you do DMSA, it is perfectly normal. So this child never had any urine infections. The history is not acute and long term, and I think as Dr. Patil rightly said, this was a voiding disturbance the child had with history of holding maneuvers. So this child actually had irritable bladder or detrusor instability, who present exactly with similar symptoms to urinary tract infections. I call it a UTI mimic. The point I'm trying to make here, I wasn't trying to talk about that. I was trying to talk about the fact that scars cannot be diagnosed on an ultrasound scan. And to finish off, finally, we have got the last 5 minutes. This was a 15-month-old girl who presented with high-grade fever. Urine showed 80 to 100 pus cells. Urine culture showed 1 lakh organisms per ml, which is significant. This child was treated with antibiotics and had all the 3 tests done. The ultrasound showed normal kidneys with mild fullness of the pelvis. Bladder was normal. A cystogram showed bilateral grade 4-5 vesico-ureteric reflux. Now, just remember here that very often people tend to mistake the fact that you will see dilatation if you have got high-grade reflux. You may not see dilatation at all. You may have perfectly normal kidneys because the ureters are very distendable. Therefore, you can have normal kidneys with grade 5 reflux or grade 4, grade 5 reflux. And this child also had a DMSA scan which showed inhomogeneous uptake in both kidneys with no scars, and the function was 46-54 in the right and the left kidney. Now, what happened was this child underwent reimplantation of the ureters. There were no complications. This child never developed urine infections after that, was seen for 3 more years, never developed urine infections in that period, and therefore was discharged from follow-up. Would you have done anything else in this child? No? Nobody? Right. If you had done, you might have done a creatinine and a protein creatinine ratio. And the creatinine might have been normal, 0.7, and the protein creatinine ratio might also have been normal at that stage. Now, what happened? Did this child live happily ever after? That if she had, I wouldn't have brought this case to attention. So what happened to this child? She
Renal
presented,
puberty.
she came at 12 years of age with a creatinine of 2.9 milligram percent. Ultrasound showed small kidneys bilaterally. And just to show you, I'm not fibbing, these are the reports that she actually had. Now remember that she had inhomogeneous uptake seen in the kidneys. And if you do not interpret this properly, you are going to miss this. What this girl had, so whether you operate or you don't operate, the uptake is not uniform. So our focus in urinary tract infection should be on kidney function. Why are we treating urine infections? We are treating so that we preserve kidney function in the long term. And if we don't focus on that, then what justice are we doing to our patients? This child had dysplastic kidneys to begin with. The inhomogeneous uptake on a DMSA scan, as I said, they may not say scarring because they don't realize that it's a dysplastic kidney. Sometimes that gets reported as scarring. And whether you operate for reflux or no, the renal function will depend on the degree of function present in these dysplastic kidneys. So the monitoring of renal function in these patients is extremely important till at least they cross puberty. Why? Because typically renal function is fine when the body size is small. So when she was 10 kilos, 12 kilos, the kidneys were able to give function because she was 15 months. But when she's growing, the maximum growth apart from the first year of life is during puberty. And at that stage, kidney function drops. And therefore, most of these children will present to adult nephrologists needing dialysis. They will not come back to you. And therefore, we will continue thinking that we have done an extremely good job in treating the reflux that the child had. So irrespective of whether surgery is done for the VUR or no, the outcome depends on the number of nephrons or the kidney function that is present at birth. And most of these may present if you don't monitor them on a long-term basis. So finally, to finish off, UTI is a common problem, but let us remember that kidneys are what we are looking at to prevent damage. It is not a catastrophe, but it should not be taken too lightly. Every pus cell is not shouting urinary tract infections. And more than just radiological tests, you need to talk to the patients to find out how the sample was taken, what are the causative factors for urine infections, for preventing urine infections. And if you are going to do the test, do them at appropriate times and interpret them properly. Don't just go by the impression that is given by the radiologist and the nuclear medicine people, because that may sometimes not be right. Thank you.
Excellent. Many
Fantastic
things
talk
we
by,
got to learn. Yes, fantastic. Yes, Anand, continue.
it was a wonderful talk by Dr. Pankaj Deshpande, and he covered the entire spectrum of urine infections, which we see in office practice with all its complications and the importance of identifying the infection, the fallacies involved in that, and appropriate treatment so that the kidney function is preserved has to be emphasized. The collection of urine is one of the biggest, the proper collection of urine is the most important, shows a lot of fallacies if not done properly. So collection of urine has to be explained to the parents. Midstream sample after cleaning of the genitals and urethra, the outer orifice, and the sample has to be tested fast within 1 hour of collection. Otherwise, you are bound to have a lot of fallacies. Now, urine reports which show pus cells do not necessarily mean urinary tract infection. A culture of more than 1 lakh of a single organism is important. floating debris and a few cells are not pathognomic of urinary infections. Importance of urinary symptoms and fever without a focus are also important. We do not just treat the urine report. Every urine infection has to be subsequently, we have to do a sonography to get a preliminary report about infection affecting the kidneys and the damage therein. USG has got its own fallacies. It does not detect scars. DMSS testing can be done after 6 months to detect scarring. Recurrent UTI is one of the commonest causes of that is constipation and infrequent voiding of urine in older children. So we have to look for post-void urine volume of more than 20 ml and treat the constipation. So very often, after the constipation is taken care of, recurrent urinary infections are controlled. In case of phimosis, we can try to increase the orifice by applying steroid cream and a little pressure. But if it does not resolve, then circumcision might be required. Very recurrent urinary infections might need trimethoprim prophylaxis, which may be required to be taken for 3 to 6 months. Vesico-urinary reflux, vesico-urethral reflux abnormal report may also have, may just be a normal incidental finding. So often we have to wait and watch and monitor the symptoms. So overall, Dr. Pankaj Deshpande has given a very nice overview of the urinary symptoms and urinary tract infection and the steps that have to be taken. Thank you very much, Dr. Pankaj Deshpande, for discussing UTI.
Thank you.
So very eloquently, and so many clinical situations have been tackled and our doubts clarified. If anybody has got any questions, any more questions to ask Dr. Deshpande,
Sir,
everybody.
any comments from Dr. Patil sir, Ramakant Patil sir?
Sir, no comments, few queries.
Yeah.
Last case, whether
Sorry,
the
last
would
case.
have last case,
Yeah, yeah.
the prognosis would have changed.
It
Even
depends.
if we have done urine protein creatinine ratio, because and is there any way other than eGFR to tell us in such cases of we have POLs or such cases, which will tell us which are the children likely to, because we have to tell them rather than just giving a blanket this thing, this child more likely to have, we have to monitor, likely to have renal failure in puberty, because sometimes it becomes difficult to disclose like this. So what is way out, and whether the prognosis really would have changed in that girl?
Right. So I think I've said this many times before. I mean, it's not live audience, but I would like to know how many of you have done your own creatinines in the last 1 year?
I have done it.
I know, because I said it last time. No, the point is that in this girl, let's say when I showed the report, if you had done a creatinine and a protein creatinine ratio, it might have been normal at that stage. So at a stage where hyperfiltration starts occurring, that is the time when you're going to get proteinuria. Now, if you are able to stop the proteinuria or reduce the proteinuria at that stage, you can prolong the longevity of the native kidney function for a fairly long time. And that's a huge boon for somebody who's going to, at 12 years now, if you're going to say this child is going to need a transplant, imagine if we can say this child is going to need a transplant at 18 or 20. You have given her 6 to 8 years going through puberty without needing any support in terms of her kidneys. So that's the first thing. The second thing is it depends on the nephron number. There is nothing in this world which can calculate nephron number. So what you can do and what each one of you should be doing is a creatinine and a protein creatinine ratio along with a blood pressure once a year. And that's what I tell my patients. I'm not asking you to do anything different. I'm asking you to do what I would tell a normal human being on earth should be doing. If you do it once a year, if you walk into a dialysis unit today, you will find so many people on dialysis. And why are they on dialysis? Forget acute cases where they got acute glomerulonephritis and went on to develop renal failure. But there are so many people who don't have any history whatsoever. So we have not monitored kidney function, and then suddenly you get symptoms when your GFR is less than 10. So if you had monitored this, you would be able to prolong the normal kidney function or continue the native kidney function for a pretty long time. So that is the answer to that. So once a year, a creatinine and a protein creatinine ratio along with the blood pressure is a must, even in a child who's undergone reimplantation of the uterus.
Sir, if in hyperfiltration cases and we diagnose proteinuria with protein creatine ratio high, are we justified in giving ACE inhibitors in these children?
Yes.
Will,
Of course. Yes.
will
Yes.
it will help?
Yes.
Yes. That's the whole point.
And
along with other measures, but yes, ACE inhibitors would be the mainstay. Yeah.
along with other measures like?
No, so you look at the diet of the child. No? So whatever is going to be harmful to the kidneys, you would want to prevent
So for to know renal function, which test should be done?
that. Don't spend too much money. 80 rupees creatinine, 100 rupees protein creatinine ratio, and a blood pressure. That's all that you need once a year.
Do recurrent urinary tract infection cause renal injuries?
Yes. Urine infections can lead to renal damage. There is no question about it. If you get recurrent pyelonephritis, you will damage your kidneys. So you need to find out the cause of urine infections, why the urine infection occurred, and prevent urine infections from occurring. If you have got normal kidneys, you will damage your kidneys with recurrent urine infection. Imagine if you have got dysplastic kidneys and you get recurrent urine infections, you're going to damage them much faster.
One last question.
Yeah.
Sir, how
Whether
to
you-
interpret that renal function report percentage? 49%, 51%,
No,
differential
so
function.
correct. No, DMSA scan, please understand that if you do a DMSA scan in a multicystic dysplastic kidney child also, where one kidney is 0, the other kidney is 100%. So a DMSA scan only gives you differential function. So it tells you how much kidney function is coming from the left, how much is coming from the right. So it doesn't tell you what the total kidney function is. So if your total kidney function is only 80%, it's telling you that out of that 80%, 50 is coming from this and 50 is coming from that. So that cannot be a substitute for your creatinine. The total kidney function is given by your simple test, which is a serum creatinine.
Sir, eGFR will be also affected if more than 80% nephrons are damaged.
Yes. No,
So-
but EG, if you look at the graph, I'll show you the graph some other time. If you in the first, let's forget the first year because that's exactly opposite. But as you grow, if you have got less number of nephrons, the first thing that occurs is proteinuria. Subsequent to that, you will have creatinine rising. So the graph is always proteinuria comes first and then the creatinine starts rising. So eGFR is calculated based on the creatinine and the height. So the eGFR will start becoming low after you have developed proteinuria in most of the cases, 90-95% of the cases.
One last question from my side, sir.
Yeah.
Which reflux you will like to give uroprophylaxis, and which reflux below only 1 year, and vesico-ureteric reflux?
No.
And
Why did you check for the reflux in the first place? Was it antenatal dilatation, therefore you checked, or was it because there was a urine infection? That would be the question. No. In any case, if you develop, for example, in the example that I gave you, she never had a urine infection. So why would you give prophylaxis there? So if you have a child who's come to you with a proven urine infection and you have now found out the child has reflux, you would use prophylaxis for a period of at least 6 months to 1 year from the time of the last urine infection. In infants, if you have detected reflux, you would continue the prophylaxis till they are at least 1 to 1.5 years of age.
And last, your gospel truth about nitrite and leukocyte esterase, if it is properly done in OPD basis as a screening and sending urine culture.
No, you are, but
The patient
more
is symptom. Patient is
correct. Because in a symptomatic patient, because if you start doing it in everybody, it doesn't mean anything.
no,
The screening test. Yes,
symptom.
correct. So it has its value, but at the same time, I was trying to tell Dr. Wankhede, I'll do it a bit later because there is something that is coming up in the next month. I'll ask you to read that and then we'll talk about this.
Where is it coming in? IAP?
Once it comes, I'll send it to all of you.
Thank you, sir.
Yeah.
Thank you. It was wonderful. Thank you, Raigad IAP. Thank you, Dr. Deshpande.
Thank you.
Thank you, sir. Thank you, sir.
Any agent, any questions? I haven't looked at all the chat questions. I think somebody asked about DMSA MCU, which age group? I think there are guidelines which are given. So less than 1 year of age, you do an ultrasound, a DMSA and an MCU. 1 to 5 years of age, you do an ultrasound and DMSA at least. And more than 5 years of age, you do at least an ultrasound. So that does not mean that you will not do an MCU in a 2-year-old child, for example. So if the child is getting recurrent urine infections, you would do an MCU, or if the ultrasound shows an abnormality. So these are based on clinical judgment of the practicing pediatrician or the practicing doctor.
So why above 5 years of age group DMS is not advised?
No, see, you need to go back to why these guidelines came into being in the first place. In 1991, the working group of the Royal College of Physicians constituted a group because what they found was that in one corner of the country, somebody was doing DMSA, IBU, MCU, everything, whereas in the other corner, nobody was doing anything. So to bring about a uniformity in the investigations, they formed this working committee, working group, and they started this recommendation. So this is where that whole idea took off. So these are the minimum investigations they suggested should be done at these different age groups. So there is no why or how. These are the minimum that were being done all over the country at that stage. So that's why they came into being. And then they have started realizing that you don't need all of those tests in all patients. So that's why further papers have been according to that. So the logic is not based on age. The logic is what was being done at that particular time in 1991. I think in the chat box, I'm saying, what's the time frame in relation to episode of UTI? I already said that ultrasound soon after the urine infection, during the admission or within 1 to 2 weeks in an office UTI. DMSA 6 months later. MCU, though they say that you can do it immediately after a urine infection, I prefer to wait 3-4 weeks because you never know whether the infection has completely cleared out and you don't want to take the risk. So you can do it immediately after the infection is cleared, but it is okay to do it 3 to 4 weeks later.
There is a question in the chat box. After how many episodes of UTI do you call it recurrent UTI?
So the proper definition of recurrent urine infection is 2 in 6 months, 2 or more in 6 months. So if you get one infection now, 4 years later, you don't call it recurrent urine infection. I think somebody asked antenatal hydronephrosis, would you start UTI prophylaxis? Not if it is suspected pelviureteric junction obstruction. Now that's a different talk altogether. If you suspect reflux, yes. If you demonstrate reflux, yes. But if it is only pelviureteric junction obstruction, the prophylaxis is not recommended. Any other questions?
What is the difference between pylectasis and pelviureteric junction obstruction?
Pylectasis, no. But on what basis are you called? Pylectasis is dilatation. So pelviureteric junction obstruction is a term that is used. You cannot diagnose pelviureteric junction obstruction. You can diagnose dilatation on an ultrasound scan. So what you are saying is it is probable pelviureteric junction obstruction. So pilectasis is telling you there is dilatation. So the AP diameter of the renal pelvis, which should be 10 millimeters, is more than that. So that's what you mean by that. So it can be PUJ, it can be congenital megauretry, it can be anything. So you are giving a name to it, and that can be diagnosed on the basis of an EC scan or a renal scan that you do later. Yeah. So detrusor instability, I actually didn't talk about that because that would have been a much longer talk. Somebody is asking about that. Drugs, depending on what you find as the aggravating factors, if you can get rid of the aggravating factors and it all settles down, then you may not need to use medications. But remember that detrusor instability or an irritable bladder is 20 to 30 times more common than a urine infection. So if you are seeing only urine infection patients, you are clearly missing bladder irritability. That's a different talk altogether. I'll come back and talk about it some other time.
So that means that at the birth, pelviureteric diameter is 10 or more. We should investigate the
Anything
child.
more than 10 millimeters AP diameter at birth has to be investigated further. Any other questions?
No, sir. No, I think there is no question. In chat box also, there is no questions.
Okay.
So excellent job.
Thank you.
Very precise.
Dr. Pankaj, a very excellent presentation, and which covered the entire spectrum of UTI cases.
Right.
Thank you very much on behalf of Raigad IAP, and thanks to all the participants who have contributed their questions and simulated our gray cells.
Thank you.
I hand over to Dhananjay Rajput to take over for the vote of thanks formalities.
Yes, Dhananjay.
Thank you, sir. Thank you. Yes, sir. This was our last subspecialty CME of this year. We are really fortunate, Dr. Deshpande, sir, renowned nephrologist, as an expert speaker today. On behalf of IAP Raigad, I would like to sincerely thank Dr. Deshpande, sir. It was a wonderful presentation as always, and which will be really helpful in our day-to-day office practice. Sincere thanks to Dr. Hemant Ganguly, sir, our IAP president, Dr. Ramakan Patil, sir, EP members, IAP, Dr. Pramod Wankhede, sir, Raigad IAP president, Dr. Vikas More, sir, vice president of Raigad IAP. Sincere thanks to Dr. Anand Wagale, sir, for his wonderful moderation. Sincere thanks to Dr. Vishal Rao, sir, for making the Zoom available for this session. And thank you all the dignitaries present on.
आवाज गेला धनंजय.
Net connection गेला.
Net connection is not there. Unstable net connection.
Yes,
So
yes.
thank you very much, all the attendees.
Thank you, thank you.
By Dr. Pankaj Deshpande, sir.
Thank you.
We are really grateful to you.
Thank you.
All the time.
Thank you.
Thank you very much. Thank you.
Thank you.
Yes. Chalo, bye. Good night.
Bye. Bye.
Thank you, Anand, for wonderful
Yes.
moderation. धनंजय. हॅलो, विकास.
हा सर.
ईबी मीटिंग घेऊया आपण 1-2-3 दिवसात.
हो हो हो. येस सर.
आता
Pramod, I need to go off. Pramod,
हॅलो.
emergency call, I have to leave.
हा, या, शुअर.
येस सर. येस सर. येस सर.
थँक्यू आनंद. थँक्यू.
Yes, sir. थँक्यू सर.
Bye.
थँक्यू
Good
सर.
night.
थँक्यू. आता एक विकास, आपण 1-2 दिवसात ईबी मीटिंग घेऊया. मी धनंजयशी उद्या बोलतो.
ओके, चालेल.
सगळ्यांना ईबी मेंबर्स सगळ्यांना आपण प्रेझेंट राहायला सांगूया.
ठीक आहे ना.
ठीक आहे.
आता 24 तारखेला संध्याकाळी असतील का सगळे?